Thanks so much for this opportunity. And first of all, thank you for AIS organizing this excellent webinar opportunity. And I think one of the things I want to mention first is, I want to thank Histosonics creating this machine. And actually, for me, this device, over experience of this device, I was connected to a lot of passionate surgeons or physicians around the world, including Takiaki. We met together because we had the same interest and we started discussing about this. And then Albert came to Rochester, and we had a lot of discussion. And now I can meet Dr. Andrew Gambus. And the common thing I always see is whenever we talk about this device, everyone's so excited and passionate, and they have always a new kind of idea concept. So I think this device is opening a lot of opportunity for all the patient and the physicians. So I think this is a great initiative. By the way, let me introduce myself a little bit. I'm Koji Tomiyama. I'm a surgical director of liver transplant, and I'm also HPV surgical oncology trained physician. So I do both liver transplant and HPV surgery. So yes, I did a first case after FDA approval, but it was not because of me, just because hospital allowed us to buy a machine. So I don't know how much credit I can take. But so since then, we are getting a lot of interesting cases, and maybe I don't know how much I have to repeat this because I think Joe did already excellent introduction. So this could be a repetition of what he mentioned. But from our standpoint, I think there are a lot of possible use of histotripsy. And first of all, obviously we try to cure by doing this treatment if it's a single region or just a few regions. So that's a kind of a mainstream indication. And I understand a lot of people are using this for palliative intent, especially when we have a neuroendocrine tumor, functional neuroendocrine tumor, or whatever the cancer that benefit from debulking. So partial treatment is the second indication. And today I'm going to actually focus on those last three indications. So bridge therapy for transplantation, that's something, we've been focusing on. And we believe, we can also convert unresectable disease to resectable disease, which Albert actually just mentioned. And we actually have a nice example case. And the last topic, last indication is kind of, there are a lot of debate about this. So I'm not going to overstate about this indication, but there's some effect that seems like triggered by this treatment, but I'm going to actually show the case later. So first indication, I'm going to talk about a bridge therapy for transplantation. So this is actually one of the, I believe, the first case of child C cirrhosis that we performed a histotripsy. I believe during a Hope for Liver trial, there's no child C disease. So basically, this patient was told, you don't have any option, and you go to hospice. That was really the situation. So I had a chance to see him in a clinic for some reason. I think a hepatologist asked me, hey, do you have any other option? And this was right before we actually bring the histotripsy here. So I told him, hey, there might be a chance to do something, but no one did, treatment on this much cirrhosis. But either way, he was almost on the waiting list for liver transplant. The thing is, his MELD score was not high, but his tumor was outside of Milan criteria. And in the US, if you are outside of Milan criteria, you cannot get an exception point, the bonus point. So his native MELD score was about 10 or 15, which is almost impossible to get a liver. But with the exception point, it goes up to close to 30, then he can get a chance to get a liver. So what we've done was we explained to him there's a chance of a decompensation. But if he decompensates from the treatment, that's going to bring another chance to get a liver transplant because his MELD score goes up from decompensation. So he understands that, and he accepts the risk because he didn't have any other option. So we did a treatment, and I was trying to be careful. And this is actually one of the beauty of histotripsy. we can plan very precise treatment. So I pretty much treated only inside of ACC so that we don't compromise any normal parenchyma, so that we can preserve his liver function. So he didn't get decompensation. I was kind of relieved, but so we followed up 1 month, and then we got a CT scan. So this kind of showed almost more than 90% dead tumor. I think there's a little bit of enhancement outside of layer where we didn't treat, but with this, he had another tumor which we decided not to treat because because of the concern of liver reserve function. But with this treatment, he become within a million criteria. And then he got an exception point. So that's kind of the highlight. We were hoping we can do transplant, but unfortunately, he had another complication from cirrhosis. I think it was a few months later. So he couldn't make to the transplant, but this is one of the cases we treated to bridge to transplant. And we did a similar case even after this, a couple of similar cases. So we start wondering maybe this could be a really good option to bridge the patient to transplant. So we actually wrote a letter to UNOS saying, hey, we have this experience and the patient is doing well. And then, we are using this as a way of downstaging. And then they said, okay, we can list the Histotripsy as one of the bridging options. So that's how they actually made it as one of the options for bridging therapy. So that's the first case I wanted to share. And the second case I'm going to show is a conversion from unresectable disease to resectable disease. So again, we are a stubborn surgeon who's not trying to give up our opportunity to do surgery. So we thought by doing this treatment, maybe we can expand the indication of surgery. So this patient with colon cancer, liver metastasis, very young patient, but underwent a lot of chemo and had a pretty good response. But I mean, the tumor start kind of not responding to the chemo. And then she came to us, when she noticed, we have a histotripsy coming in. So we discussed about potential liver transplant. By the way, I'm going to talk about liver transplant for colon cancer, liver metastasis. That's one of the things we are focusing here. She was not a candidate for liver transplant, unfortunately. And we talked about resection option. When we do an aggressive resection with a limited reserve, we can do a 2-stage hepatectomy or Alpus procedure. But the problem is, this one lesion, the big lesion in between left hepatic vein, middle hepatic vein, to resect this, we have to take a entire left lobe. But at the same time, she had multiple lesions on the right lobe. So this made her disease unresectable. But we discussed with the patient and we decided to treat these 2 left side lesions with a histotripsy. So we did it, and then we follow up with a scan. Fortunately, there's no sign of a residual tumor 6 weeks after histotripsy. And then we actually decided to go ahead and perform a right hepatectomy and primary resection with a colorectal surgeon. So it worked well. She did very well with the surgery. And this is kind of a follow-up of what happened to those left side lesion after resection. So this was our early experience. I think it was actually a first case. So we were taking a CT scan at a multiple time point. We could actually see nice kind of progression, or not progression of disease, but progression of treatment. So this is one of the longest follow-up we have now. It's actually went over 300 days now, but unfortunately, she developed a lung disease, lung mets, but this area is almost gone, and she's still alive. And unfortunately, I cannot say cancer-free, but I think that this is one of the good examples of how we can expand the surgical indication by utilizing this technology. So the last one, again, I have to be careful how much we can see this non-treated area effect. Some people call this abscopal effect, but there are a lot of debate about this effect because we don't see this a lot of time, but I believe it's probably something beneficial in certain settings. And in fact, this is the same case as the second case. I mean, when we treated the left lobe, before right lobe resection, we look at the right side, and she didn't have any chemo, but it looks like it's smaller. So that's, I believe, Joe, you can correct me if I'm wrong, but this is probably the first observation of a possible non-treated area effect on a human example. And after this, this is probably one of the best response we had. So again, this is a colon cancer liver metastasis. And this patient started having a resistance to chemo. He was running out of the option. So he came to us, and then we basically treated the easy target in a lateral segment here. And this is a case that I was kind of surprised because initially his treated area got bigger. And I thought it's a progression, but it got smaller later. And I think this is what people call a pseudo progression. But another interesting observation is, this treated area looks kind of very irregular. And I sometimes see this kind of response after histotripsy. And I'm actually working with our radiology to review all the past cases, and then maybe we may have to assess the treatment effect in a different way from other local regional treatment options. But again, we didn't treat this area. And he had a chemo, but he was developing a resistance to chemo. So it was not responding before histotripsy. And unfortunately, again, this effect didn't last forever. So he showed a progression of disease. But this is one of the best response we've seen after histotripsy on a non-treated area. So that started kind of convincing us maybe this is something we can utilize. So we had a couple of cases that we could actually resect non-treated area. The conversion case I presented is one of the good examples. So we start collecting those samples and start doing immunostaining. So obviously we see a lot of immune cell infiltrating around the tumor. Something interesting is I think if the tumor has a lot of fibrotic tissue, that area doesn't have a lot of reaction or response. And we see the same thing on a treated area. If the treated area has a lot of fibrosis, desmoplastic changes, it seems like those areas resistant to treatment. But this actually goes to the comment that Joe made. The dose is fixed at this point, but maybe in the future, we can adjust the dose depending on what's the intention of treatment, like treating as a curative intent versus, try to trigger, this non-targeted area effect. So that's something we can do research in the future. And this is another case. There are two cases that we did immunostaining. Again, a lot of immune cell, and we don't know what this means yet, but at least there's something going on in a non-treated area. So with this, so we're trying to, this is just conceptual kind of stuff we have here, but we are focusing on transplant oncology practice here. And for those who are not familiar with transplant oncology, this is basically the very kind of simple idea. Transplant is replacing the organ for end-stage organ failure, and oncology is treating any type of tumor. So we think replacing the organ may cure some of the cancer disease in the liver. However, the challenge is transplant always need immunosuppression. For oncology purpose, immunosuppression is not good because tumor suppression usually comes from a patient immune system. So that may lead to a tumor progression. So that's why we have to make sure the tumor or each patient has a good tumor biology. That means we have to confirm a good disease stability. And that's why we do a lot of chemo. And chemo works really good for especially colon cancer these days. But one of the challenges we're having is before we do a liver transplant, we have to remove primary. And that's when we may actually see a progression because we have to hold the chemo. And we are wondering if we can utilize histotripsy and some systemic kind of a protective effect from those immune system stimulation. Maybe we can lower the risk of progression during the patient is off chemo. And also we see a lot of patient, who's kind of getting sick and tired of chemo while waiting for the transplant. And this may actually give them some break and then time to recover their liver function. So I think those are the potential utilization in the future. And again, we have to do a lot of research to prove this concept. But since we have in a unique situation of having a transplant oncology, having this machine, we kind of start thinking about this indication. That's all I can share for today. And thank you so much. I can take any questions.